Good morning, everyone. We'll make a start, I think. Welcome to today's webinar, which is part C of the Continuous Quality Improvement and Practice Incentives Program, Quality Improvement webinar, part of the High Performing Primary Care series. I'm Paresh Dawda, and we'll make a start. Whilst we're waiting for maybe a few more people to join. Of course, we'll start with an acknowledgement to country, and we acknowledge the Aboriginal and Torres Strait Islander peoples as the traditional owners of the lands and pay our respects to their culture, their people, and elders past, present, and future. Just a sort of copyright warning on behalf of AGPAL that the presentation slides and all the material content are copyrighted by AGPAL. The use of the material is prohibited unless a specific written permission by an authorized representative for AGPAL. I'm Paresh Dawda, I'm a GP in Canberra, and I won't go through this slide. This is the third in the series, and I think most of you have met me by now. So as we come on to this, this series put together is really a series of 4, focusing around high-performing primary care. And of course, it's supported by the Northern Queensland Primary Health Network through the Commonwealth Government's PHN program. So it's only right that we should acknowledge that and thank them for that support. So as I mentioned, this is one of 4. This one's on continuous quality improvement and the PIP QI. There is a second one on the RICGP 5th edition accreditation, a third one on population health and digital literacy, and a final one on integrated care. The aim of the series of 4 is really listed on this slide here. So this is around how we achieve the quadruple aim, and the enablers for that. So that includes workforce capacity, having a culture of continuous quality improvement, recognizing that the system at large is trying to enhance primary care, and so there are incentives and initiatives going on in the system, both at Commonwealth level, but sometimes at state and jurisdictional level, supporting primary care. And so how do we capitalize on leverage of some of those? Also recognizing that technology and the use of digital technology in particular is a big enabler. And so there's a lot of focus on the use of digital technology, particularly as it relates to the sort of intelligent use of data to drive improved health outcomes. It is about sustainability, and it is about joining up care and integration. So the outcomes from this particular stream and series are listed on here. And really, I would draw your attention to the application of the model for improvement in conducting authentic PDSA and developing a system for measurement for improvement as being the 2 key elements we're going to really talk about today. So this particular component's been spread out over 3 webinars. The first one on the 24th of September, we really talked about the why and built up that sort of case for why this is important and why we need to do it. Last week, we talked about the what, and we talked about quality management systems. We touched a bit on model for improvement, and we talked about PIP QI and implementation plan. We talked a lot about tools last week as well, so understanding systems thinking and why it's hard to get the outcomes that we're looking for. So we talked quite a lot about that last week, and then we talked about some tools we can use to help us understand what's going on a bit better. So we talked about things like root cause analysis and process mapping and so on. And so today is really thinking about the how and really putting what we've learned in the last two webinars into practice. So today is really interactive. We'll work through the content, but I've got lots of questions in the slides as we work through it, and I'll be inviting you to sort of comment and give ideas. So I really welcome that interactivity and conversation. I think that's what will really make today's webinar be, I think, more useful for you. Is the more we engage in a dialogue, the more utility you'll get from today's webinar. So I'd encourage you to do that. At the end of last week's webinar, I did leave you with maybe a task to consider, and that's that mirror exercise and sort of looking at that self-assessment. Just wondering how many of you have had a chance to look at that, and whether you've done that as a practice or looked at it and reflected it on individually, and what your thoughts were. So feel free to either unmute yourself and tell us, and I think that would be the ideal way. But if you're unable to speak because of being in a workspace where there's other people around, then feel free to use the chat functionality as well. So we've got stunned silence. I might take the silence to move on. Thanks, Emma. You haven't had the opportunity yet, and look, I understand that there's a lot going on, and it's often difficult to look at these things. But I'd encourage you to sort of consider it, and the way I guess we'd propose you could do it by sticking up in the staff room, giving people stickers. It's quite an engaging way. People can do it over a short break, over coffee, over lunchtime, without it taking too much time. We might come back to that at the end of today's webinar again. As well as looking at that activity last time, I just wondered whether anyone had any questions from last week's webinar, or any other comments or reflections. Any questions that emerged after the webinar for you? Okay, thanks, Emma. So no questions, just lots of ideas to implement. That's great that you've had lots of ideas. It is amazing how much one can do in this kind of space, and once the ideas start flowing, they don't stop as well. So the important thing, I guess, is to capture those ideas and think about how you might prioritize them, and maybe we can come on to have a discussion around that towards the end today as well, as part of a Q&A session. Any other thoughts, any other reflections from anyone else? Okay, well, in that case, I may move on. And really, as I said earlier, today's objective is to describe measurement for improvement, to develop a goal-driven, authentic PDSA. The interesting thing about using any of these tools, particularly things like model for improvement, is if they're done with the fidelity with which they're designed, then they work much better. So I guess really want to focus, and it may even at times come across a little bit pedantic, so I'll make an apology for that right at the beginning. But the reason for being pedantic about the model for improvement is to make sure we get that fidelity with which it was designed. Because in my sort of experience of doing quality improvement for probably the last 15 to 20 years in healthcare, what I've seen is a lot of PDSAs and model for improvement isn't used with the fidelity with which it's designed, and so we don't really get the bang we're looking for with it. Linked in with that measurement for improvement is understanding when a change is an improvement. So the first point and the last dot point are connected in some ways. Again, just a reminder that we'll be talking a lot about the what today. As I talk about the what, use those reflection sheets to contextualize that for yourselves. So what does it mean for you, for your practice, and how you do quality improvement? And then again, towards the end, it's then really thinking about now what? What will you do as a result of what you've heard today and your understanding of how it applies to you in your context, your action points, what's your action plan? Because that ultimately is what's going to make the difference for you and your patients based on what you've learned from these 3 webinars. So again, encourage you to use that reflective element. Any questions at this point before I sort of talk about the model for improvement and move on to that? Okay, great. Let's move on. So many of you will have seen this, right? So this is the model for improvement. When we think about the model for improvement, there's 2 parts. There's the thinking part and the doing part. The doing part is the PDSA cycles. Now, PDSA cycles, I think last week, one of you said, you call them PDSAs, plan, do, check, act. The concept of PDSAs has been around for a long time. Forms an part of approaches, Lean, Six Sigma, or the model for improvement. 3 questions at the top were improvement, and so from a lot of guests were doing around improvement 90s, applying people like Deming, who did a lot of improvement with the Japanese motor industry, Motorola, General Electric, who did a lot of work around Six Sigma and that kind of stuff. So they were beginning to apply the thinking in healthcare. And in terms of the work they were doing with healthcare and their reflections from it, they came up with these sort of 3 questions. What are we trying to accomplish? How will we know that a change is an improvement? And what changes can we make that will result in improvement? And so they put those 3 questions together with the PDSA to really come up with a model for improvement. And that's been used a lot in healthcare since the 1990s. It's probably one of the most popular tools used in healthcare, and hence the focus on that. So when we're thinking about the model for improvement, and there's 3 questions, what we're trying to accomplish, well, that's really about our aim, right? It's about our goal. Where are we trying to get to? Um, Question 2 is about how will we know that a change is an improvement? And that is to say that, unless we can measure it in some way, then we're not going to know whether we're improving or not improving. Part of that is around understanding variation. So we talked last week about Deming's profound system of knowledge having 4 components. One of those 4 components was around understanding variation. So we need to really understand variation to know whether we're making an improvement or not. And you'll see from some data I share with you later today why that understanding of variation becomes important. And then we've got what changes can we make that will result in improvement. So again, when we look at some of those tools we did last week, whether it's the process mapping or that root cause analysis, the London protocol type of approach, and you drill down around why you've got a particular issue or a particular problem, not achieving a particular goal, you actually find that it's not one single cause, there's multiple factors that contribute to that. And therefore, when we're making changes, we need to make changes in lots of areas to help us address those multiple factors to get to the goal we want to. Which of those changes will work, which of those changes won't work, we don't really know that. And that's where the model that's where the PDSA, the doing part, comes in. It's really about picking one of those ideas and testing that in our system, in our practice, and seeing whether it has the desired impact or not. And sometimes it takes a few test cycles to get to a place where it has the desired impact. And once we've done that testing and we see that it's got the desired impact, we might make it a step in our process, make it the usual way we do things, so it becomes a sustainable change rather than a sort of one-off intervention. And a year or 2 later, we're back where we were. So that's the theory of the model for improvement. The measurement part is such a fundamental component of this. And what I'd like to do is share with you, and I hope the technology works here, a video, which is actually from the NHS, a guy called Mike Davidge, who I did some work with in the UK, really describing why and how to improve, and really the concepts around the data and capturing the data. So this is a YouTube video, and I'm going to try and play it now. It's about 7-8 minutes long. I'm hoping the technology works. Sometimes videos on Zoom don't always work very well. If it doesn't work, I'll apologize in advance, and I'll of course share the link with you so you're able to watch it at a later point in time. But let's see if the technology works.
Hello, I'm Mike Davidge, and I'm going to talk to you about measurement for improvement. So why do we measure? Well, it's said there are 3 reasons why we might do that, and the first is very familiar to those who work in the NHS. This is a form of measurement where we have to achieve a particular target, often given to us by other people, using data that again often is given to us by others, or at least we're told what we need to collect. In its worst form, this leads to a tick box mentality, and achieving the target becomes the end in itself. The second is familiar particularly to clinicians, and that's when we're trying to discover new knowledge. For example, when we're trying to assess whether this new drug is worth investing in. And this involves a well-constructed trial and collecting lots of data to enable us to distinguish between the effects of the new drug and the existing treatments. Now, measurement for improvement is neither of those. So, what is it? Those of you familiar with the model for improvement will know that it asks three questions. What are we trying to achieve? How will we know that a change is an improvement? What changes can we make that will result in the improvement we're looking for? Now, measurement for improvement is aimed specifically at answering that second question. We're trying to see whether the changes we're making to the service we're involved with are actually moving us in the right direction. In other words, are we moving closer towards achieving our aim? So how does this happen? Well, good measurement doesn't just happen by chance. We need a good process. And I'm going to outline to you the 7 steps that make up this good measurement process. Step 1, decide aims. It's surprising how many projects start off with aims that are too broad or too vague. And this leads to problems when we're trying to measure the effect that that particular project is having or has had. So try this simple exercise. Imagine you're getting into a lift with a colleague and you're both going to the 3rd floor. And you've got the amount of time it takes the lift to go from the ground floor to the 3rd floor to explain what it is that project's trying to do. If you can do it in that time, then you have a good grasp of what you're trying to do. Step 2, choose measures. If we simply list all the different things we might measure, we often come up with a list that's quite large, and it's difficult to know which are the most important. And so there are a couple of techniques that do help you to structure that list of measures that you might have come up with. One is to look at the map of the process that you might have completed as part of the earlier stage of the project. Looking at that process map may give you some ideas about where the most important points are that you might want to pick up. The second, if you have constructed a cause and effect or a driver diagram, you can use that as well to focus in on where you might select appropriate measures for your project. Step 3, define measures. We've chosen the measures we want to use, and now we have to be clear exactly what we mean by them. Let's take an example. We've decided we want to measure complaints. Well, exactly how will we do that? Are we talking simply about the number of complaints received? Are we talking about the percentage of patients who complain? Are we talking about the number of complaints we receive per patient? Taking time to define your measures is important because it provides consistency over time. We've now come to the end of the preparatory phase of those 7 steps. And now we move into the collect, analyse, review cycle. Step 4, collect data. So we need to establish what data items that we need to collect. In our example about complaints, we've gone for the percentage of patients who complain. And so in this case, we'll need to collect the number of patients who complain and the total number of patients. And who's going to do it? We need to be clear whether it's ourselves or whether we're delegating that responsibility to somebody else. How are we going to collect the data? Are they from hospital systems or other sorts of organisational systems, or are they through bespoke surveys? When is the data being collected? Are you doing it real time, or are you looking back over data that has already been collected? And finally, when we're embarking upon a project, we want to know how we're performing now, to act as a baseline against which we measure our progress. And therefore collecting data to establish that baseline before we get into any improvement is important. Step 5, analyse and present. The way that you present your data has a crucial impact on the way you react to it. So choose your methods carefully. For data about numbers, that is quantitative data, then you'll do that by turning your data into charts. And there are 2 types of charts that are useful to you here. The first is the RUN or SPC chart. This helps you to answer the question, how am I doing? Have I improved? A useful further tip is to annotate those charts with the changes that you make when you made them, so that you can see that the change resulted in a difference. The other type of chart is the bar chart, or sometimes called the Pareto chart. You use this to help you understand what are the causes of the particular thing you're looking at. So for example, back to our complaints measure. The Pareto chart is really useful to help you understand what are the most common complaints, and therefore where might you tackle next in terms of making an improvement. For data about words, that is qualitative data, then you might want to display that in terms of a story, a video clip, perhaps a storyboard. That helps to get the message across about what that data that you've picked up, perhaps from patient stories or interviews, is telling you. Step 6. Review measures. The purpose of collecting our data is to help us make better decisions. That doesn't happen by chance. We need to make time as a project team to look at our data regularly and decide what to do next. Are we getting the outcomes we're expecting? What is the data telling us about changes, good or bad? And finally, so what do we now need to do? Step 7, keep going. And the final step tells us that we should go back to step 4, to collect, analyse and review again. In other words, go round that collect, analyse, review cycle. So how often do we do it? Interestingly, when I ask people in courses and seminars about that, they often say monthly, because that's the natural cycle of reporting in the NHS. But there's nothing magical about that monthly cycle. In fact, a weekly cycle of collect, analyse and review is much more useful, because a week is a much more discrete time period and people can often relate to what happened in a particular week, which helps to put the measurement into context. And how long do we go round this cycle? There are certain measures that you might be using, particularly measures of process, that once you've achieved a certain level, for example, percentage reliability that's consistently around 100%, you can stop collecting that data. There are other measures, and particularly often this is measures of outcome, particularly patient outcome, that you will want to continue measuring for as long as that service exists, because those measures define how well you're doing in that service. And finally, looking at this data and understanding what it's telling you will always tell you when that particular project has reached its aim, and therefore it's time to stop and move on to something else.
Okay, I might just stop there and see whether you have any questions from that video. It's a lot of information in that video, and we will go into elements of what Mike talked about in that video at different points in today's webinar. But are there any sort of burning questions or points of clarification that emerge for you from that video? Okay, so one of the things I guess that came out from that video, and it's worth thinking about when we're thinking about quality improvement, is the type of measures. And broadly speaking, we can have 3 types of measures. I actually think there's a 4th one, which I'll mention as well afterwards. But Mike in that video talked about outcomes and measuring outcomes. So that's that's actually what we're trying to achieve at the end, right? So the health status, the quality of life, knowledge, behavior. But that's sometimes hard to measure as well. So for example, and I'm going to pick diabetes as an example, how many of our diabetic patients die as a result of the diabetes, so the mortality from diabetes? That would be an outcome measure. How many of our diabetic patients have an amputation because of their diabetes and a complication from foot disease? The amputation rate is an outcome measure. It's an adverse outcome. We've mentioned in the past the concept of patient-reported measures, and patient-reported outcome measures are also valid outcome measures we could think about. A lot of the measures we do in healthcare are often more process measures, and we talked about this last week. And when you look at a lot of the QI PIP measures, a lot of them are process measures. So these are, reliance on the fact that if we do certain things, they will lead to a better outcome. And therefore, if we measure how often we're doing those certain things, those interventions, then that's a valid measure because it's hopefully going to get us to better outcomes. So, when if we look at diabetes again, the percentage of our diabetic patients who had a foot check every year is a process measure. The percentage of our diabetic patients who had an HbA1c checked is a diabetic measure. It's a process measure. Now, in between the process and outcome measures, sometimes we have what are called proxy outcome measures. So they're not really outcome measures, but we know there's been enough research to tell us that if we get the proxy outcomes, they will translate into an outcome. So for example, in diabetics, if their HbA1c is below 7%, we know that leads to better outcomes and less risk from chronic kidney disease and foot disease and retinopathy and so on. So we'll often measure the percentage of our diabetic patients who've got an HbA1c of less than 7% or 7 to 8% to try and see how we're doing with our proxy outcomes. So that's just another thought to keep at the back of our minds. And then we have structure measures. So these are around the facility, the equipment, etc. So, how many people in our practice do we have that have been trained in how to do a foot check? It's a structural measure. A variation of a structural measure could be your capacity measures. So for example, if you have one nurse who's trained in how to do foot checks and that nurse only works half a day a week, but you've got 500 diabetic patients, there's a mismatch of capacity and demand. So the number of hours we have to deliver a component of care could be a structural measure. So when we think about measurement, we can measure structure, we can measure process, we can measure outcomes. Outcomes are sometimes hard to measure, so we can measure something in between called proxy outcome measures. In quality improvement, the other thing people sometimes talk about when they talk about measurement is balancing measures. So these are the unintended consequences of quality improvement. So, for example, a balancing measure that's often used is the length of a consultation. If we do A, B, and C in the care of our diabetic patients, we might find the length of consultations increases with the clinician, and the unintended consequence of that might be we get complaints from other patients that they're having to wait a long time before they get into their appointment because the doctor, the nurse is spending longer with the patient, with the diabetic. So that might be a balancing measure we might choose to measure as part of our quality improvement. So that's the fourth one, which I mentioned at the beginning. That's not on this slide. But most quality improvement experts would sort of suggest that in a significant quality improvement project, think about the unintended consequences and whether you need to measure the unintended consequences or not. Let's just start with a case study. I'm just going to ask, how many of you have, if any, have done any work on osteoporosis and quality improvement around osteoporosis? If you have, feel free to, okay, great. So you did some in the past, Emma, thank you. If you've done some work in quality improvement work around osteoporosis, please feel free to throw in your experience of it. But one of the reasons I picked osteoporosis is because, again, it's one of those areas where a lot of people haven't done work in that area, and so I wanted it to be a sort of clean topic, as it were, not prejudiced by any particular experiences you've had, and so that's a reason for picking this. But this could be any clinical topic, right? So we have guidance on osteoporosis, okay, and this is a one-page summary of what that guidance shows or tells us. I'm going to just focus on this left-hand part, okay, of the guidance, which is, and what this guidance tells us is for men and women over the age of 50, if they've had a fracture of the hip or the spine from minimal trauma, then really we should be going down to where this orange box is and starting them on treatment with an anti-osteoporosis medication. We, of course, do the lifestyle things as well with them. And so that's the pathway I really want us to focus on for the purposes of, our hypothetical quality improvement project. Just bear in mind that if the minimal trauma fractures at any other site, so it's not the hip or the spine, but let's say the wrist, then the guidance says do a DEXA scan, which is a way of testing for osteoporosis. And if that's abnormal, then we treat them. But if that's not abnormal, we might consider referring them to specialists, but we certainly would give lifestyle factors. So if there's a borderline abnormality there. So that's what we're looking at. I'm just going to turn off the video to see if that helps the clarity of the pictures and images you're seeing. Okay, so let's just think about that. Now, what's a case for change? Okay, so do you remember we in previous webinars talked about the anatomy and physiology of change? So there's a technical side of change, which is, the measurement, the root cause analysis, the process mapping, doing the PDSAs, and then there's the physiology of change. That's about engaging people, the human side of change. So let's just pause for a moment. And if we were going to do an improvement project in this space, how will we approach that and why do it in the first place? Okay, so here's a case for change. We know that more than 50% of postmenopausal women and 30% of men will suffer at least one minimal trauma fracture during the remaining lifetime they had. They talk about a fragility fracture or a low impact fracture, and this is defined as, you know, a fall at the same level. So if someone's standing up and they have a fall and they've fractured a hip, that's a fragility fracture. If they're standing on a ladder 4 steps up and they have a fall and they fracture their hip, that's not a fragility fracture. That's not at the same level. So we know a fragility fracture is, if you like, the angina before the heart attack. So somebody who's had a vertebral fracture or a forearm fracture, they've got a high likelihood of getting a hip fracture within a couple of years. So data from New South Wales tells us that percentage chance of them getting another minimal trauma fracture within 2 years is 46.5%. Getting a hip fracture is actually pretty serious. 20% of people with a hip fracture will die prematurely within 12 months. We also know that it's an under-recognized and an under-treated problem. So we've got research data that tells us that we're probably only treating 9 to 20% of fragility fractures. There's 80% out there we're not treating. So that's what the research tells us, right? But what does this mean for us at our practice level? How can we extrapolate all that knowledge, all that information, and what does it mean? So let's look at a hypothetical practice of 5,000 patients. These are 5,000 active patients, male and female. Okay. Out of our 5,000 patients, 15% will be over the age of 70. 40% will be over the age of 50. So that translates into 750 people and 2,000 people. How many of the patients in our practice are likely to have osteoporosis based on that research? Well, 15% of women over the age of 50 have osteoporosis, right? So in our practice of 5,000, 150 of them will have osteoporosis. 30 men will have osteoporosis. How many of them are likely to have had a fragility fracture? Well, when we do the data and the number crunching, 71 of them are, okay? And when we do the search on how many of them are actually on treatment as per the guidelines and the flowchart, it's 22 people. So in other words, 49 people are not treated. Okay. So that's about 32% of them treated. We'll bear that statistic in mind because we'll come back to that. Okay. And bear in mind, this is about treating people who already had a fracture. So this is the highest risk group that we're looking at. Has anyone got any questions on that data? So we're going to come back to that data in a moment, and we're going to sort of think about how we might do an improvement project and a PDSA for that. Okay, so we'll come back to that, but let's just go through and really think about, remind ourselves, what does the model for improvement say? Okay, so we've got the 3 questions. What are we trying to accomplish? How do we know that a change is an improvement? And what changes can we make that will result in an improvement? We'll come back to those 3 questions and answer them collectively as a group in a moment. What I want to just do in the next 2 or 3 slides is take you through what the research in this area tells us, okay, around the model for improvement, PDSAs, and what key features of PDSAs are, and then we'll come back to sort of applying that to the problem at hand. Okay, so what the research tells us in this area is, PDSAs are really about learning to see whether an idea is going to work in our practice or not. Okay, and so when you see a lot of diagrams around PDSAs, they show nice diagrams where you do one PDSA and there's an improvement, then you do another one, there's an improvement, you do a third one, there's a further improvement. It's a nice line going upwards. The reality of PDSAs actually looks a bit more like this, right? Because you do some PDSAs and they work, you do others, they don't work, then you do something else and it gets a bit worse, and you do something else and it improves. And so the whole idea of PDSAs is about developing knowledge of the system and what works and what doesn't work. So again, go back to what we talked about last week and Deming's 4 components in his system of profound knowledge. One of them was about developing knowledge of the system. Okay, and so that's what PDSAs allow us to do. So overall, our trajectory should be one that's improving, but it's okay for PDSAs to bounce us around as long as we're getting learning from that. In this piece of research, they analyzed, I can't remember the exact number of PDSAs, hundreds of improvements analyzed. And I think they found it's almost around the 15% mark of PDSAs were actually done with the fidelity with which the tools design. 85% of them weren't proper PDSAs. And so this really brings me on to that, reinforces that point I made earlier about the importance of fidelity when we're using these tools. So I played this slide last week, okay? And, when we think about osteoporosis and the number of people who had a fragility fracture, I guess most of you, like me, when I first started thinking about this, kind of thought, yeah, this probably goes on, but I just need to work out how to improve things. I just need to give this some headspace.
Coming downstairs now, bump, bump, bump on the back of his head.
So
it is, as far as he knows, the only way of coming downstairs, but sometimes he feels there really is another way. If only he could stop bumping for a moment and think of it.
So the question is, how do we find the time to stop the bumping and think of a different way of doing things? And, is this a necessity? Do we really have the time to wait to do that? So key message about PDSAs is they don't need to be complex. They can be simple, so you can build them into your everyday workflow. So we're constantly improving rather than waiting to find time. So we can do one big PDSA. That's not the idea. The idea is to recognize the problem. Yes, find some time to work out where we're going, what the aim is, but then the PDSA should be able to happen in business as usual way rather than taking up too much time. And so that's really what good continuous quality improvement looks like, is that it happens on a daily basis. In that same paper, they looked at some of the features of good PDSAs, and this is a list of what the research sort of came up with in terms of what a good PDSA is. So the first thing is it's iterative, right? So any change idea will have multiple PDSAs, not just one PDSA. the lessons from that one PDSA informs the next one, that informs the next one, that informs the next one, and so on, until we get to a point where we either modify the idea, expand the idea, adopt the idea, or abandon the idea. PDSAs are about testing a hypothesis, a prediction, to see whether that works in our system or not. It's small-scale testing, so constantly when you're doing PDSAs, think about how you can make it really small. And we'll come on to this when we think through our example of the minimal trauma fracture. It's about frequent measurements. So Mike Davidge on that video kind of talked about, most of the time we measure monthly. We really need to be measuring much more frequently than monthly, because what we really want to be doing is understanding the variation that's existing in our practice, in our data. And if we just measure monthly, we're not going to get a good understanding of that variation. Once things are stable and working the way we want it to, then moving to monthly measurement or quarterly measurement is fine. But in that improvement stage, we probably want to be measuring much more frequently. And then the final is documentation. So, write down your PDSAs, what you're doing. Have that template of recording your PDSAs, and make it a habit to do so, because that's what gives you your record, that's what gives you your learning, that's what gives you your evidence also to demonstrate that you're engaging in continuous quality improvement for external bodies like accreditation and so on. So let's come back to our case study. Okay, so, we looked at our current state, we looked at some data, we know the evidence recommendation from that guidance tells us a minimal trauma fracture of the hip or spine in a person older than 50 years of age is presumptive of osteoporosis, right? Treatment can be initiated in those patients. So that's the evidence recommendation we're looking at, and that's where we're going to do our quality improvement. Okay. If our measure was the percentage of patients with a minimal trauma fracture of the hip or spine older than 50 years who are receiving treatment with anti-osteoporosis medication, if that's our measure, then our current achievement is 32%. Make sense so far? So let's come on to the three questions in the model for improvement. Okay, and the three questions are: what are we trying to achieve? How will we know that a change is an improvement? And what changes can we make? So, if we're thinking about this guideline, what are we trying to accomplish? Would anyone like to volunteer a goal for us for this project? Any volunteers? So, Emma, increase the bone density testing. Are we able to speak to that, Emma? Are you able to unmute yourself and maybe talk around that? Oh, okay, no worries if you can't. So I'm just going to go one slide back. So we're looking at this part of the guideline. And in this part of the guideline, there's two steps, right? You got minimal trauma hip or vertebral fracture on the left. And if someone's had that, then you can go straight onto treatment without doing the DEXA scan. Okay? If they've had a fracture of any other side, then DEXA scan and then make a decision based on that. So I guess it depends which part of the pathway we're looking at, Emma. I think if we're looking at trauma fracture, any other site, then absolutely increasing the bone density testing may well be part of our goal. Janine's made a comment about identifying the smokers in the risk group. And so again, if we go to the previous slide, addressing the lifestyle factors, smoking is definitely a part of that. So it could be part of the goal we want to do, but is that goal big enough? Is that going to help us achieve things higher up the pathway, which is where the gap is? Any other thoughts? So thanks, Emma, for sharing that. So you did a drive of increased bone density testing of patients that meet a certain age, medication, and at risk group. Yep. So you're really looking at identification of osteoporosis in your cohort. But let's think about that first question. What are we trying to accomplish? The goal is one that we need to derive at a practice level, right? So it's an important, everyone's got to be on the same page with the goal. And you can see from just the brief conversation that we've had, people will have different ideas about the goal and what we're looking at trying to achieve. And so setting the goal together as a practice through a dialogue and conversation is really pretty important. Then there's looking at your goal and seeing whether there's any way you can self-assess your goal to see whether you're sort of going in the right direction. Now, there's been some training material in the references at the bottom of this slide called the QI CAT tool, which was really a training tool for junior doctors being trained on QI. And in this training package, they were given some questions they could use to self-assess the goal, for example. And so the questions they were given are, is your goal focused on the system level of the problem presented? Okay. So the problem presented is patients who had a low impact fracture in our practice aren't on, or enough of them aren't on anti-osteoporosis treatment. Okay, and only 32% are. Does the goal statement include a direction of change? Does it include a characteristic around the magnitude of change or timeline? So we can once we put our goal, we can self-assess our goal against those three criteria. Our goal needs to be a measurable goal. And so how will we measure that goal and know whether we're getting there or not? In a similar way to how you can self-assess the goal, you can also self-assess the measure. So does it explain what we will measure, the timing of measurement, and how we will communicate the results? And in a similar way, the changes we make can be self-assessed as well. So will the small steps work towards the goal? Are the changes we're making, do they have a methodology around them? Are they realistic and achievable changes? Are the changes we're making measurable? Okay. So if we put all that thinking together, what we could get is something that looks a bit like this. Now, I'm not saying this is the right answer. What I'm saying is this is something after we have a dialogic process and conversation with our practice team members, we could come up with. Okay. And so let's just think about the self-assessment of the, those three self-assessment tools I just talked about. Let's just think about their application to what's in this slide. So what are we trying to accomplish? Our goal: have 60% of our patients with fragility fracture on appropriate treatment by June 2021. So if you remember, the three things on the self-assessment were, is it focused on the problem? Well, we're focusing it on fragility fracture. Does it talk about a trend, either an upward trend or a downward trend? Well, we're looking at going from 32% to 60%. So maybe we could refine this statement and say we'll increase to 60%. And does it have a magnitude of change or a timeline? Well, we've got a timeline there, and I guess we've got a magnitude of change as well. How will we know that a change is an improvement? Well, we could look at the number of patients who had a fragility fracture who are on appropriate treatments, and we'll plot that on a chart, and we'll annotate our charts with the improvement efforts, similar to the way Mike Davidge talked about in the video. Okay, so but our metric will be the number of patients with a fragility fracture on appropriate treatment. So our numerator will be the number of patients on appropriate treatment. Our denominator will be the number of patients with fragility fracture. Okay. So what can we do? What are the ideas of change? Well, we could do a whole bunch of stuff, right? So firstly, we could review our patient lists and make sure that we're really just looking at active patients. We've inactivated patients who have not been to the practice, perhaps deceased patients. So, that kind of change can apply to any quality improvement project, right? It's about having your data clean, so you know what your baseline is and where you're starting from. We could review a list of patients over the age of 50 with fragility fracture as a diagnosis to begin with. We could review the free text diagnosis of a fracture. We could search for patients on osteoporosis medication with no diagnosis of osteoporosis or fragility fracture and identify who the missing group are. So they're just a quick few select ideas for change. Do you have any other ideas for change with respect to this project we could use? Okay. So let's just assume we accept that as a goal. And we've got our measure, so we'll know whether we're, or we'll have an indicator at least to assess whether we're improving or not. Let's think about a PDSA and writing a PDSA, and let's just focus on the plan bit, okay? So when we're thinking about the plan for a PDSA, we really want to be thinking about who, what, when, where. You know, what's the hypothesis or prediction that we're going to make, and we really want to develop a plan for that change idea to test that. Okay. So here's an example PDSA. Okay. What are we going to do? We're going to review all the correspondence that comes in from the emergency department, so to see if a minimal trauma fracture can be identified for patients who attended the previous weekend. Okay, so one of the predictions, one of the hypotheses here is that, you know, we're not identifying patients who had a minimal trauma fracture. Often that fracture is diagnosed in the emergency department. They might not come to us. So it's going to be diagnosed in the emergency department. When we get the letter back from the emergency department, we're not really picking up that they had a minimal trauma fracture. And so the prediction is, if we were to be able to do this, and maybe the nurse is able to identify the minimal trauma fracture, that's the prediction, then we might be able to code it at the point we get that letter from the emergency department. So that's the thinking, that's the idea, that's the hypothesis, right? So what we're going to do is we're going to ask Nurse Emma to review the letters. And what will happen is the receptionist will, after scanning the letters, because that's what we do in this practice, the receptionist opens them and scans them straight into the doctor's inbox. But what we're actually going to do for this PDSA is, because we think the doctors probably won't code it, and if we could get a nurse to maybe identify them and do the coding, then that would work. But we don't know, you know, how time consuming that will be. We don't know whether the data will be there in the letter. So we're just going to test this, right? So over a weekend, all the letters that come in, the receptionist will scan them as usual, but we'll also put them in a separate folder. On Wednesday afternoon of that week, at the practice, Emma, our nurse, is going to look through and see whether she can identify patients with a minimal trauma fracture. Okay. The way we're going to study whether this PDSA has worked or not is we're going to look at the number of letters that come in, because, you know, we want to get a sense of how time consuming, how big a task is this. We want to see how many patients Emma identifies, because again, you know, ultimately we want to see, is the effort worthwhile? We'll maybe measure the time it takes, because, you know, if 30 letters come in but it only takes Emma 10 minutes to go through them, well, that might be worthwhile, but if it takes an hour to go through them, that might not. So we'll maybe measure the time taken as well. And, you know, what we'll do is we'll also check, because this letter's going straight into the doctor's inbox, you know, and our current process is the doctor's responsible for the data. So if they think it's important, they'll code it. We'll just maybe look to see how many of these patients were coded by the doctor. So that's the plan. Okay, so it's very specific. It's very small. Okay, we're going to do it on Wednesday afternoon. So we've sort of really segmented it down. We're just going to pick the letters that came in over a weekend. So again, we've segmented it down, and we really thought about what is it that we want to learn from doing this PDSA. And we've thought about the data that we're going to collect to help us get learning. Has anyone got any questions about that plan? Okay, if not, then we might move on. So the next thing is we do the plan, right? It's when, the receptionist scans the letters and assigns them to the doctor as usual after the weekend, places them in a separate folder for the nurse. On Wednesday afternoon, Emma carries out the PDSA as described. And she collects the data, and what we find is there's 22 letters that came in. 2 patients had a minimal trauma fracture from those 22 letters. It took Emma 29 minutes to do that, and neither of those 2 patients were coded as having a fracture or osteoporosis risk by the GPs. So that's a learning we've got from testing out the idea. Okay. So what do we do next? Well, one thing we could do next is go on and explore with the doctors their reason for not coding, just to sort of get a sense and understanding of what the barriers there are. Okay. That might then take us on to a completely different PDSA around how we can make it easier for the doctor to do the coding, or it might bring us back to this PDSA where we repeat the PDSA but with another nurse, for example. So that's that bouncing around sort of PDSAs in that slide I showed you earlier from that research paper. I'd like to just pause and ask you to reflect on that PDSA, and what are your thoughts about that PDSA? Think about the key features of the PDSA cycles, that slide I showed you a little bit earlier, and how does it match up with that? So Ginny, got a question, wondering how you communicate the ACT part with the GPs. And then Emma, checking discharge summaries may prove to be a challenge. So how do you communicate the ACT part with the GPs? I guess it'll depend from practice to practice. It's, again, probably about having a conversation with the doctors, and it's probably about just doing a one-to-one. So, bear in mind, one of the precursors to all of this was when setting the aim of what we're trying to achieve. One of the things I said is it's really important to have a conversation. It's about having a dialogue with your practice team to make sure everyone's on the same page. So, assuming that's happened and the doctors have been part of the aim setting the goal, the conversation becomes easier to have in the ACT part, which is, we've done this PDSA, and this is what we learned as part of the PDSA. We're wondering what you find, and again, when we look at the physiology of change, that human side of change, one of the contexts is really about a humble inquiry rather than making judgments about this. So the humble inquiry is asking open questions. So we just would like to, we're wondering what are the challenges around coding for patients when you're looking at a letter that comes through the emergency department. What would help you to do it better? What would make it harder? Who do you think is the right person to do it? All those sorts of humble inquiry type of questions become really relevant to sort of seeking that understanding. I agree, Emma. Checking discharge summaries can be challenging, and I agree. GPs often check incoming results from home at different times, etc. One of the ideas or thoughts that have been implemented around this in various practices that I've worked with in terms of quality improvement is, some practices have had a clinical coder who does a lot of the coding. Doctors often won't do the coding, but they're asked to highlight a key diagnosis. So they would highlight the minimal trauma fracture, and a clinical coder would then do the coding to make sure you get consistency of coding. So that's one process in some practices that has worked. A second process, some practices will say, we do regular housekeeping data searches. We search for patients who are on bisphosphonates but haven't got a diagnosis of osteoporosis regularly, to make sure our register is as valid as possible. Now, that sort of housekeeping search wouldn't work for this particular problem we're trying to solve, but it might help keep our osteoporosis register tidy. I'll just move on, but keep the questions coming through, because I think it's, that's the real important part of the conversation and learning from today's webinar, is to really be discussing the thoughts from what I'm presenting. We're going to just move on to the measurement piece, right? We talked earlier about the different types of measures. We've got structure, process, and outcomes. Let's say we started off this quality improvement project, okay? And what we're measuring is the percentage of patients with a minimal trauma fracture of the hip or the spine who are older than 50 years and they are receiving treatment with anti-osteoporosis medication. And we've got 3 data points. Are we improving? I'll ask you all to either type in a yes or no into the chat box based on whether you think this graph tells us whether we're improving or not, or don't know. So Janine, yes from you, we're improving. Yes from Samantha. Others? Okay, so we've got a few yeses. Okay. If we expand the chart, what we actually see is that we're not improving up until we get to data point 15, 16. And that's when the improvement occurs. Okay. And this really speaks to what Mike in the video was referring to around the frequency of measurement. Okay, and it speaks to what we mentioned in Deming last week. One of the components of the 4 components of his system of profound knowledge being around understanding variation. And so we have 2 types of variation. Okay, we have a variation that's called common cause variation, and we have a variation that's called special cause variation or assignable variation. The best way of thinking about this is, if I was to ask you to write your name 10 times with your dominant hand, each of the time you wrote your name will vary slightly. It will vary based on the pressure you put in, the position of your dominant hand. The fact that by the time you got to the 7th time, you're probably getting a bit bored of writing your name, and then you still have 3 more to go. There'll be a little bit of variation between each one. That's common cause variation. It's, if you like, the noise in the system, and it's how the process works. Just as we have that common cause variation in how we write our name, we have that common cause variation in our data as well. So data will go up and down depending on active patients, patients leaving the practice, new patients coming in, new doctors, coding, how we code, how we don't code, etc. So there'll be day-to-day variation, week-to-week variation, month-to-month variation. If I then asked you to write your name with your non-dominant hand, it will look very different to the 10 times you wrote it with your dominant hand. That's special cause variation, or assignable cause variation. That tells us that we've got the improvement we're looking for. Now, I'm not going to go into the depth around the science of all of this, but I think it's important to understand that you do have these 2 types of variation. The way you tell the difference between special cause variation and common cause variation are through a set of rules. In order to know whether you're getting special cause variation or common cause variation, you need to have the power comes from frequent data measurements. So the statistics, the theory from all of this tells us that you need at least 15 data points before you can make any sort of decision. If you are measuring on a monthly basis, that's 15 months before you know whether you're getting common cause variation or special cause variation. That's the reason Mike in the video says you are better off measuring more frequently, particularly when you're starting an improvement project and actively working on something. Weekly or even daily is better than monthly, because if you're doing it weekly, well, you'll get your 15 data points over a 3-month plus period. If you're doing it daily, it'll take you 2 to 3 weeks to get your 15 data points. Once we start plotting our data in this way as a run chart, we can annotate and we can see whether we're getting an improvement or not. And we can then adjust our charts to show that improvement. So if we go to the next slide, you can see that at day 16, not day 16, at data point 16, we had enough evidence to say that we had a assignable cause variation, that the changes we were making were actually leading to an improvement. And then we can readjust the mean or the median value, and we've got a step change in our performance. Yeah. The reason we know that that's assignable cause variation is because one of the rules around recognizing this is whether you've got 6 or more data points all going up or down, or you got 6 or more consecutive data points, either all above or below the median line. And so we've got that, right? So we've got 1, 2, 3, 4, 5, 6, all above the median line. And so we know we've got a assignable cause variation, we can adjust the mean, and we get this nice step change in improvement. We're still not at our goal. Remember, our goal was to get to 60%, but we can see we're working towards our goal. We talked about reliability in last week's webinar. And I gave you that evidence from the 2 research papers done by Elizabeth McLean around how appropriate care is on average delivered 55% of the time. I talked about how anything less than 80% in engineering terms is described as chaos. Okay, that's where health systems are generally operating at. Then we make improvements, and when we make the improvements, we get to a higher point, but it's still not at that high performance end. It's still not at that 90% plus end. The usual changes we make to try and get an improvement are often focused on sort of vigilance, hard work, intent, written policies and procedures, personal checklists. So, individual doctors might have their own checklist, but they don't all have the same checklist. We're often feeding back information on compliance. We kind of, we'll often say to people, look, work harder, just try and do that coding when that letter from the emergency department comes in. And by the way, you don't only have to code for the osteoporosis, you've got to code for the ischemic heart disease and diabetes and the COPD and so on. And we might have an education session, an awareness session, and say to people, oh, look, this is what the osteoporosis guidelines are, this is what we should be doing. But then, in 2 weeks, we might have an education session on something else, and then something else. So we kind of rely on these sorts of strategies to try and get higher performance. And all of these strategies are necessary. The problem is they're not sufficient on their own to get the higher reliability. To get the higher reliability requires all of what we've just talked about, but also more, right? So it requires a focus on human factors, that sort of human-centered design concept. It requires standardization of processes based on best available evidence. So if you remember last week, we talked about process charts, and I showed you that process chart where a letter comes in and 3 different doctors look at it, and each one does things slightly differently. That's a non-standardized process. Standardization helps us get to a better place in terms of performance. Understanding variation and minimizing variation helps us get to a higher performance. The next bullet point around making desired action easy as default action actually relates to the human factors things. So, if you make it easy to do the right thing and harder to do the wrong thing, a bit like what I talked about when we looked at that London protocol last week, then that helps us get to a higher performance. If we try and build it into existing habits and patterns that people are using within the system, then that helps us get to a higher performance. And so I was just trying to think of a good example in healthcare around tying things in with existing habits and patterns. I'll maybe come back to that. I'm trying to think of a clinical example that would work well. So, in hospital medicine, for example, a lot of hospitals are now doing a preoperative surgical checklist, and anything new that might be introduced becomes introduced into that surgical checklist. So that's an existing habit, and then they're adding to that to make it happen. I'm trying to think of a general practice example. And I guess, you could almost maybe look at something like a surgical checklist within general practice as well. Before minor op, I mean, we often have immunization checklists. Can you tie something in with that? But the final concept around getting high performance, and if you think back to that London protocol I talked about last week, even designing everything perfectly may mean sometimes it won't happen, and so we have to build in mechanisms to prevent failure and remind people to do the things that are right. Has anyone got any questions on that? Again, that's quite a lot of information. Thanks, Emma. I completely take that point around trying to digest information. It is a lot of information. The last part, as we sort of head into the final part of today's webinar, is really thinking about how we communicate the information. And communicating data in a visual way is really powerful. We have lots of ways we can present data visually. So you've got the bar charts and the pie charts. The data quality indicators we often get from PenCat and things have these RAG ratings, red, amber, green ratings, which sometimes are helpful. As Mike said in that video, the two most powerful ways, I think, of communicating data is the run chart, because a run chart, particularly when you start annotating it, actually tells a story. And it tells a story over time. And then the Pareto chart Mike talked about, which is really a bar chart, but the bars are organized in order of frequency. Is again really powerful to try and explain the reasons behind your run chart, really. So he used a complaints example in the video. You can use, for example, if you were looking at the osteoporosis medication issue, the problem we highlighted, we could use a tool like the root cause analysis or the process mapping tool we talked about last week, to try and better understand why we weren't getting the percentage we were aiming for. And then we could plot on a Pareto chart all the reasons that contributed to why we weren't getting the target we were aiming for in order of frequency. And then that helps us prioritize where we might perhaps start off our improvement. The final point, I guess, is about sustaining the change. So Mike in the video talked about, when things are stable, you might reduce the frequency of measurement. The important thing is you continue measuring. I guess my slight disagreement with Mike on that video is he talked about how you can stop measuring things at times. My kind of view is you should continually measure things. You might just reduce the frequency of measurement depending on how stable things are. But unless you regularly measure, you're not going to know whether the change has been sustained or not. And if you go back to the presentation, I think it was last week, could have been the week before, I talked about the 4 habits of high-performing organizations. And one of those 4 habits is measurement and oversight. And it sort of talked about how some of the really high-performing organizations that research came out of had 300 plus measures that they measured on a regular basis, which can be, and I completely understand, it can be time consuming. So it is about prioritizing and making sure you selected your measures correctly. I guess my take-home message is, if we don't continue measuring, then we don't really know whether we're going to slip away or not. And so that's pretty important. So as we come to the final part of the 3 webinars, this whole stream around quality improvement and PIP, I just wanted to remind you of that activity around the mirror we talked about last week. And I appreciate in the last week, many of you won't have had the time to do the activity, but that's a really good starting point for us to think about where we are as a practice in terms of a whole quality improvement approach. So these are the 5 indicators on that self-assessment. Performance measures being comprehensive and include mix of clinical, operational, and patient experience, and that we're feeding that back to the care team. So there's a feedback loop and a learning cycle. That we're using our clinical information systems as optimally as we can to support our quality improvement and population management. And our clinical information systems have a lot of limitations, but notwithstanding that, are we making the best of what we can with our clinical information systems? Are we reviewing the data regularly as a team? And are we using that data in our caregiving? So before a patient comes to us, before identifying gaps in care and actually outreaching to patients across a whole bunch of chronic diseases and risk areas, are we doing that? Are we reporting on our processes of care and the outcomes those processes are delivering, not only internally to our practice teams, but are we reporting them externally to patients, other teams, external agencies? The PIP QI, of course, has perhaps taken us on that first stepping stone there, where those indicators go out in an anonymized way to the PHN and ultimately to AIHW, where it's aggregated. But do we produce a set of quality accounts to demonstrate our accountability to our patients, to our communities? Should we? So there's at least one practice I know of in New South Wales who is putting all their chronic disease data as run charts on their website with a little bit of narrative around what the run chart's showing and what they're doing in their practice to improve. So that's sort of external reporting. And the final ones around measuring patient-centered interactions by making sure we're getting input from patients and their families on the totality of care delivery issues, and then using that to incorporate that into our quality improvement. And are we actually using patients and consumers in our quality improvement? So they're the 5 criteria around which that self-assessment is done. And then, like I say, doing that as a team then allows you to sort of measure yourselves with where your strengths are, where the opportunities for improvement are. And then that allows you a reflection as a practice again around, does that self-assessment hold true? Where can you improve? How will you address those areas of improvement? Could you apply the model for improvement in PDSA for that? So in the last few minutes, we'll just very quickly recap. So continuous quality improvement, we've talked about the why, we've talked about the what, and today we've talked about the how, really focusing in on measuring and model for improvement. You've got the self-reflection sheets, a lot of content, and I think, the last two webinars, there's probably a lot more content, whereas today's been more about application of that content. And so I hope today's perhaps just giving you, has been a bit thought-provoking maybe, but giving you some ideas as well to think about what else you could be doing to build on your strengths and what you're already doing. So, think about the so what, and what will you do as a result of all three webinars really, and what you've learned. And to just remind you that, we have got 3 more in streams in the series, the next one being on the 5th standards.